Welcome back to my channel. I'm with the new video, and this time the topic is ancillary therapy during mechanical ventilation. Now, uh, even if it is ancillary therapy, I think it is one of the most important pivotal component of mechanical ventilation. So, again, uh, as my practice goes, I have divided into couple of short videos. So let us start. I'm sure every one of you have watched this very famous movie Munna Bhai MBBS, and it has this very famous Jadoo Ki Jhappi, where Sanjay Dutt actually greets everyone with this jhappi. So we need to also give jhappi to our patient in the form of fast hugs bid, uh, at least twice in a day, and that is a mnemonic, and this is one of the most important quality indicators, especially in the ICU in the life of an intensivist. So this Jadoo Ki Chappi, where we start with fast hugs bit, as we know that F stands for feeding, A for analgesia, S for sedation, T for thromboembolic prophylaxis, H for head of the bed elevated, U for stress ulcer prophylaxis, G for glucose control, S for spontaneous breathing trials, B for bowel care, I for indwelling catheter and infection control practices, and D for de-escalation of antibiotics. So this is, if you ask me, in the today's era of intensive care practice, this is the most important and something which every intensivist should kind of address. Now let us start with each component in an isolation. I will embark upon each of these in a bit of detail, starting with feeding. So everyone should get feed, especially in ICU. Predominant route will be the enteral, and here we aim to deliver calories and of course the proteins. And why it is important is to mitigate the deleterious effects and the adverse effects of catabolic processes which happens in ICU. So it should be initiated early, place of nasogastric tube which is as soon as possible when the patients get intubated and ventilated, or for patients who are unconscious, who are not awake, who are drowsy, who are not able to handle their airways, and because of which we have kept them nil by mouth, and of course we will have to depend upon nasogastric tube for the feeding, or where there is expected ventilation for more than 40 hours. As I said, enteral loose route which is preferred over the parenteral route, and enteral route is the very famous quote goes as either you use it or you lose it. As a standard practice, I would deliver about 25 to 35 kilocalories per kg per day of total energy, and a protein in the dose of zero point 0.8 to 1.5 gram per kg per day of proteins. Of course, the patient needs fluids, and this could be to the tune of 30 to 35 ml of fluid per kg, with allowance for the extra losses either from the drains or fistulas, or extra input from the other sources. And of course, the nutritional requirement may be double for a critical ill patient. Enteral route, as I said, the patient with accessible GIT should be fed via a tube into the stomach, and with the upper GI dysfunction or with a post pyloric feeding, and usually PEG or percutaneous endoscopic gastrostomy, which is instituted in patients likely to have long term feeds, especially for more than 4 weeks or 4 weeks of enteral tube feeding. As far as parental nutrition is concerned, very few subset of patients may need that, where you have an inadequate or unsafe enteral nutrition or a non-functional gut, inaccessible or perforated GIT. So these are probably the absolute contraindication for enteral nutrition. We administer parental nutrition or PN via a peripheral venous catheter when the short-term parental nutrition of less than 14 days is expected and who have no need for central access for other reasons. And of course, I would add up here when we have serum osmolarity or the osmolarity of the parenteral fluid which is more than 1000 milliosmoles, we need to have a central line in this patient and along with the patients who will need a long-term parental nutrition. Now, so if you remember the mnemonic, if it goes as fast hugs bid. So after F, of course, A comes and it is analgesia, which is adequate pain relief, which is must. And pain can be due to tubes, the suctionings and the positions and the lines, and so on and so forth. Of course, use of NSAIDs, acetaminophen, and opioids in proper appropriate cases. And of course, morphine and fentanyl also are very commonly used in patients, especially in ICU. And talking about fentanyl, which is there could be a threat of hemodynamic instability. Continuous infusion of analgesia is more effective than boluses or as and when required. So we need to actually aim for a proper dose of, say, IV infusion in the form of either fentanyl or any other opioid. Talking about S, which is sedation, and this is a Ramsay sedation score levels, and it's a very famous kind of scoring, as you could see on your own, with the points starting from 1 to 6, and where 1 is patient is anxious and agitated or restless, and when 6 is the extreme, when the patient is asleep, shows no response to light globular tap or loud auditory stimulus. And the common sedative agents which we institute in our ICUs is, of course, benzodiazepines, which forms an important mainstay against the patient who needs sedation in the form of either midazolam, lorazepam, and diazepam. Opioids like morphine, fentanyl, and pentazocine. Anesthetic agents predominantly in the form of propofol and ketamine. Alpha 2 agonists, which are commonly in use in the form of dexmedetomidine, and of course antipsychotics in the form of haloperidol. So it's important to have a daily wake up cycle, and as a protocol in my ICU, I would probably stop a sedative drip at 5 o'clock in the morning to assess the neurological functions during the daytime. So, this is a famous NEGM paper published in 2000, which talks about the daily wake up cycle and avoid paralysis until the oxygenation is difficult to optimize, which will cause less self harm. And so here, as you could see, that you have a routine sedation and the daily interrupted sedation, and when there is definite the patients who are receiving mechanical ventilation, there is a high chance that the patients would get weaned off in the patients who get sedation free interval, and which is not very difficult to understand. So friends, here I would like to stop. We just finished the S from the mnemonic, that is sedation, and we will continue this series in my next upcoming videos on the ancillary therapy. So that's all for this time. Bye bye. Take care.